So there are major challenges in ensuring access, and the most common IVDs for cancer include aging technologies that are ripe for innovation to improve quality, accuracy, and access. So in this regard, UICC FIND and the American Society for Clinical Pathology, with the support of QBio, developed a report to highlight the role of IVDs in early detection and to also explore the barriers in access to IVDs and outline ways to address them and discuss the future of IVDs in early detection and their potential for use in point-of-care settings. So in order to discuss these issues I just mentioned in more detail, it is my pleasure to welcome our expert panelists. As authors of the report, our first two speakers will talk about the report specifically, and our third speaker will add to the discussion by talking about the findings of the Lancet Commission on Diagnostics. I also want to point out that the links to all of the resources I just mentioned, the IVD report and the Lancet Commission, etc., are included in the chat box for your information. So our first speaker is Beatrice, who is Scientific Officer with the Foundation for Innovative New Diagnostics, or FIND. And her role was initially for the hepatitis C program, and she's now the lead for the non-communicable diseases diagnostics as well. So Beatrice has 15 years of experience in the field of viral infectious diseases, both in academia and the industry. In fact, prior to joining FIND, Beatrice worked at Roche Diagnostics as International Product Manager for infectious diseases. And Beatrice will talk about the various barriers and challenges to accessing IVDs. Beatrice, please go ahead. The floor is yours.
Excellent. Well, thank you very much, Shalini, for this kind introduction, and welcome everybody. It's really a pleasure to start off this dialogue to elaborate on the various barriers and challenges to access to IVDs and some key enablers that have the potential to improve access. And yeah, we can start off with the first slide. Thank you. So I wanted to enter here with a quote from our Goodwill Ambassador, Aminata Touré, who very rightly said that we've known for some time that testing is the weakest link in the care cascade, really preventing individuals from accessing the care they need, and also depriving decision makers of the data that could enhance the effectiveness of healthcare delivery. And outside of cancer, I think nothing better than the COVID situation has shown us how dependent we are on IVDs to actually know what's going on. And of course, that applies to all diseases. So if we move to the next slide, really thinking about the types of barriers that can we can broadly classify them into these 7 categories now shown here, which are the regulatory pathways, quality standards, supply chain, laboratory services and infrastructures, training and retention of workforce, cost, and accessing health services. And these are really, like I said before, applicable across IVDs and are closely interlinked, and depending on what kind of disease area we look at, some can play more of a stronger role than others, but really it's a whole framework and complex system that interplays to really bring barriers, but also present opportunities to enable better access. So if we move I want to go through all these 7 points very quickly a little bit now, based on what we have actually in the report, to summarize it here for you and further elaboration within the report, highlighting here the key barriers and enablers for each of these topics. And starting at the beginning of the journey, if you like, after development is done, how do we ensure high quality IVDs availability in the country? So this is really through strong regulatory pathways and quality systems in terms of laboratory capacities. And what we often find in LMICs is that complex and varying regulatory pathways and limited local assessment capacities impede easy registration of high quality or new IVDs in the country, because it is a barrier for manufacturers to enter to understand in each country how best to get there. And a key enabler is really the potentially adoption of unified regulatory requirements through widening of WHO prequalification processes or other mechanisms that will lower that barrier for manufacturers and countries to actually have a regulatory access in the country. And in addition to this, of course, we need high quality laboratories, which are often lacking in a way in terms of accreditation level, as well as quality assurance programs to assure consistent availability of good and accurate results. And here we also know of some initiatives from WHO as well as other quality assurance programs that are set out to strengthen lab accreditation and implementation of mandatory QA programs. So with this, if we move to the next category, is really looking at, once we have the registration in country, of course, barriers and gaps in supply chain, laboratory services, and lab infrastructure can often be in the way of getting reliable diagnostic services, of course, because supply interruptions, through stockouts, due to inadequate forecasting, inventory management, distribution systems, limited shelf life. We all know that this can happen at any rate for any diagnostics, and I think cancer diagnostics are particularly vulnerable because they're often in low volumes, making it a little bit more difficult also to apply lessons learned from other enabling exercises with higher volume diagnostics, such as HIV, in terms of improving supply chains. And then, of course, lab services and lab infrastructure are always a challenge, and particularly cancer IVDs, which can be a little bit more complicated the way they are today, needing electricity, power, water, IT infrastructure. So they can only, they really might only be available at tertiary level or in very select facilities. So here an enabler could potentially be integration of lab services, improving specimen reference systems, point of care diagnostics to get away from the complexity of a laboratory, or certain laboratory network initiatives. And it's been shown, like you see in the quote down here, that integration of services, of HIV services and cervical cancer services can actually improve access and overcome some of these barriers. So if we move to the next slide, please, we will see that, once everything is in place, we have the laboratory and infrastructure addressed now. It comes down to the training of the workforce, because healthcare provider training is so essential to provide a quality diagnosis. So not only is it getting the accurate test in a reliable way in a laboratory or at a testing site, of course, we need trained workforce. We need people to be able to interpret results and action accordingly. However, of course, we know that there's a big gap in training often, or absence of continued education. There's a high migration of workforce often, where then training efforts are lost. And of course, there's a gap in the lack of availability of qualified physicians. And there's specific ideas and enablers around to try and improve that, and are implemented. Specifically, task shifting has been proven quite useful at times to work closely with individual capacities and then broader healthcare workers to support decision making. That already brings me to the next aspect, actually, on the next slide, which is accessing of the health services by the patient. Now we looked at the systems aspects of it and the physicians and the interpreter of the results. But what about the patients? Of course, good access to health services is crucial to increase chances of early diagnosis and minimize delay in care seeking. And here, of course, accessing a service to get a diagnosis or a screening test even is often impeded by these being far away from where the patients live, because often cancer services are only provided at tertiary or secondary level, and really not very much at the primary healthcare level. So strengthening the primary healthcare level would potentially enable more access. But then it also comes to the fact of stigma, embarrassment, fear of procedure, personal barriers that may stop a woman, for example, to go for a cervical cancer screening. And here there's a very nice example of the Project Rose, where self-sampling was tested out, where the woman can sample in the privacy of her home, send the test in, get a result through an eHealth digital platform, without sort of having to go specifically necessarily to a healthcare service until a result comes in, and which may need her to go and seek more dedicated care. So, and the very last barrier, of course, is the cost one on the final slide. Without going too much into detail, if we just move to the next slide, going into the detail about these specific costs, of course, financial and economic barriers must be removed to access cancer IVDs for early diagnosis, because we know that often there's high out-of-pocket spendings. Treatment is prioritized over elaborate diagnosis because the resources are so limited. National screening programs are rolled out at times, but could be rolled out wider and potentially to additional aspects. And yeah, what are the enablers? It's increasing investment in cancer screening and prevention, integrate cancer screening in primary healthcare under the QHC umbrella, implementation of essential packages of cost-effective cancer control interventions that have been generated, data have been generated and recommendations made sort of at the WHO level. So looking towards that has potential at the country level to reduce that cost barrier, if not to overcome. And that already brings me to the final slide, actually, by saying, how do we improve access? There are, over the last years, a number of initiatives have taken place in a promising aspect for laboratory infrastructure in general. We've seen an increased global investment in health programs to improve lab infrastructures and give countries tools to assess their lab infrastructure to improve, to understand where investment is needed. On the regulatory aspect, not only is there, of course, the WHO PQ process, where there's still some opportunities for cancer IVDs, but in general, it is a process that is in place. WHO has also piloted a collaborative registration process for several countries to facilitate in-country product registration and make that a bit easier. And increased service integration has been demonstrated to work and is definitely something that can be built on. And last but not least, of course, there are IVD innovations, bringing tests to the point of care, self-sampling, self-testing, use of digital health. And we'll hear a lot about this in the next talk from Dan. There's also an opportunity to improve access here. So really all our collective learnings from these initiatives of laboratory strength and quality improvement, care integration, and so forth can pave the way for broad improvement in access to cancer IVDs in LMICs. Thank you.
For the clear picture on the challenges and also for providing insight into ways to address these, including the example of self-sampling, lab network initiatives, and also expanding the WHO pre-qualification or PQ process to include cancer diagnostics, etc. And now our second speaker is Dan, who is the Chief Medical Officer with the American Society for Clinical Pathology. And before joining ASCP, Dan spent 11 years at Harvard, where he taught pathology, microbiology, and infectious diseases. Dan began working in Africa in '97 as a medical student and has built an international reputation as an expert in cerebral malaria. But in parallel with this, he has also been heavily involved in pathology capacity building in many countries. Most notably, he led the team that built an anatomical pathology lab in Rwanda and Haiti for advanced cancer diagnostics. So across the landscape of cancer care, many new approaches to IVDs are approaching or becoming standards of care. However, all of these are at different levels of readiness for use in low and middle income countries. And this is what Dan will talk about today. It's over to you, Dan.
Thanks so much. Can we have the next slide? So I think in order to understand the future of IVDs, we really have to understand where we're coming from and where we're trying to go. So in vitro diagnostics for cancer really have remained static for many decades. But as we have seen, if you look in the literature, if you follow this area, there's really a rapid evolution that's happening with diagnostics, which is paralleling what's happening with therapeutics. There are many new medical therapeutics for cancer, and they require either companion diagnostics or access to certain types of traditional diagnostics in order to use those drugs. And so this sort of parallel rapid increase is happening, which is really important. But on the traditional side, there are really three major areas that we think of when we're trying to diagnose cancer. And all three of these are diagnostic procedures. These are not typically what we think of as screening procedures. There are screening tools that we use that may use parts of these, but what I'm referring to here is the ability to diagnose someone definitively. These are the three areas that we use. So there's traditional histology with immunohistochemistry, where the massive cost in that process is the immunohistochemistry, just to be clear, but this involves processing a tissue from fresh tissue to wax, thinly slicing it, staining it, and interpreting it by a board-certified anatomic pathologist, which is an important concept as we move into the modern version. In cytology, which can also include immunohistochemistry, we collect cells or prepare fresh, fixed stained tissue, interpret them, again, by a board-certified anatomic pathologist. And then lastly, there's flow cytometry, which not very many people are familiar with outside of the diagnostic arena or the oncology arena, but this is where we use fluid or blood or any kind of fluid really that can contain cells. We stain those cells with antibodies, count them by a laser, and interpret them by a board-certified anatomic or clinical pathologist. So on the traditional side, we have 3 different methodologies, all of which require a board-certified pathologist to read and interpret them to make a diagnosis. On the modern or evolving side, these new tests that are happening, or these are things that are happening today or are evolving. The first and most important probably for today is diagnostics. And this is the idea that, a pathologist has made a diagnosis on histology or cytology, et cetera, but now the clinician needs a second test to be performed on that same material in order to dictate treatment. The diagnosis doesn't change, it just decides which treatment that patient needs. A good example of that is estrogen receptor for breast cancer to determine that the patient needs tamoxifen, or HER2 amplification to determine that the patient needs trastuzumab. In both of those cases, knowing that the patient is ER positive or HER2 positive does not change the original diagnosis of breast cancer, but it allows the clinician to make a treatment decision, hence a theragnostic. The 2 other areas are focused molecular diagnostics, which can include point of care. This is where tissue, cells, or liquids are analyzed for the presence, quantity of an RNA, DNA, or protein, and then reported and interpreted by a licensed professional. Now note that I don't say a board certified pathologist. The goal of a point of care test is that it doesn't require a pathologist to interpret it. The downside of that is it has a more narrow focus. So these point of care tests, although they can be very powerful, they're limited to the tests that are included for point of care. So an example would be the Gene Expert Breast Strat 4 cartridge, which looks at ER, PR, HER2, and Ki67. That's a point of care test that can replace the need for immunohistochemistry and can be interpreted by a highly qualified lab professional. Doesn't have to be a pathologist, but it only does those 4 tests, and it's only for breast cancer. So great answer, but limited focus. And then we move to the more developmental R&D area, which many companies are actively engaged in, which is multi or pan-cancer diagnostics. And this is the analysis of a comprehensive panel of cancer-related markers that's automatically reported and or interpreted by a licensed professional or directly interpreted by the clinical team. And notice here, we've taken away the need for necessarily a lab interpretation. It could be a clinician that's interpreting it. And there are examples of this now. There are KRAS and other tumor marker panels that are available in 4 to 5 plex versions. But there are also these blossoming technologies like multi-cancer early detection or universal cancer screening testing, which are looking at 20, 30, even up to 50 cancers in a pre-invasive stage to determine if the patient has those diseases. And so that you can see from the left, we have a requirement of a lot of infrastructure and personnel. And on the right, we have a lot more focused technology, but with a lot of cost. Next slide. So here we can look at all of that testing in a matrix of complexity versus cost. Now across the bottom is complexity, and this is really all of the complexity, how many people you need, what equipment you need, where the test can be done, the type of reagents, et cetera. So from the point of view of just logistically getting the test done is complexity. And on the other axis is the cost. How much does it just cost to do that test if you combine all that together? And to some degree, those may seem related, but they're a little bit different. And notice that cytology or cytology with the cell block is quite low cost and can go, but still starts with a little bit of complexity because you need a pathologist to interpret that material. And if you look in the far upper right, you'll see standard molecular testing. This is what we do today. It's quite complicated. It has expensive reagents. We often do it 1 test at a time, or we do sequencing of a whole tumor, which gives us hundreds of genes, but requires a lot of complicated interpretation, a lot of reporting, et cetera, and has a very high cost. But notice our 2 new tests that we mentioned, point of care molecular and multi-cancer screening. In the case of point of care molecular, the complexity becomes very, very low, right? It's a cartridge, for example, that you put blood in and press a button. So the user that can perform that test is much less needed, much less capacity is needed for them to be able to do it. And it's almost a walk-away test that gives them an automated result, but the cost is still pretty high. So it's not going to replace cytology today because the cost is just too high, but it's certainly complexity-wise much easier to deploy. And then multi-cancer screening is really a little bit stressful for the pathology community because the cost may be high today, but the complexity is low. And even if that complexity can be avoided, especially in sites where we don't have that infrastructure, that multi-cancer screening or any kind of tool may be superior from that point of view because we don't have to put all this other infrastructure in place, which is a point I can talk about a little bit later. Next slide. So, and this is really a key image that I want you to take home, which is that when we think about an IVD or in vitro diagnostic, especially a future test that we're working on and we're developing, in a high-income country, United States, for example, even if that test is performing really, 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 really well, it's not perfect, but it's performing well, it's only going to create what's called operational efficiency, right? Currently, there's a complex system for finding and diagnosing and treating patients. And in order to push that system further, it has to be a really amazing test. So even if we had a great multi-cancer screening test right now, not a perfect one, but a great one, it's going to have some increase in our efficiency, but it's not going to change the industry to say. But when that test becomes near perfect, when multi-cancer screening or universal cancer screening tests or any kind of multi-panel detection that's going after more than one cancer using a molecular tool can really outperform or perform as well as or better than our traditional methods at a reasonable cost, then it's going to be a disruptive process. But you can see that difference between operational efficiency and disruptive innovation for a high-income country is not very much, right? The test has to go from almost perfect to do that. But if we look at a low-income country, that's just not the case. Because of lack of infrastructure, because there just aren't resources there now, even a poorly performing or a minimally allowed performing test could be transformative for cancer screening in a low resource setting. And in fact, if it becomes transformative, it becomes disruptive even at not a perfect level. And I think that concept is really important because we, for too many decades, have tested strategies in the US, in Europe, with rare populations where it was really difficult. For example, we start with advanced melanoma, metastatic melanoma to test a drug, and then we work ourselves backwards to stage 1. And those patients are rare in the US, and it takes months and years to do those trials, the same with the testing, et cetera. But when we move to an LMIC, some of these diseases are much more common, the populations are much more readily available, and those tests would have a much higher impact just because of the level of disease that we see in those populations. So again, a take-home point here is that as we develop these strategies, the access to use of and research and development within LMICs would be transformative and disruptive, even in the early stages of those. And we shouldn't let perfect be the enemy of good. Next slide. Just a really quick contrast here. In a high-income country, a patient often has insurance, they have a fiscal means to pay, they have access to multiple clinicians, they have access to multiple laboratories, and they can easily seek a second opinion. So the tests that we utilize in a high-income country have to be affordable relative to the information that's available. They have to be competitive, right? Better performance than others because patients have a choice. They have to be high quality, and they have to produce an actionable result for clinicians. Well, in a low-income setting, they also have to be high quality, and they have to produce an actionable result for clinicians, but the other motivations are different because patients have limited financial resources, they have limited time from presentation to treatment, and they have limited access to clinical services. So there's usually only one or no laboratory options. So tests really have to be low cost, and this is non-relative, meaning they absolutely have to be low cost, and they have to have a rapid turnaround time because patients may not be able to stay around for weeks and weeks while waiting for a result. So the motivations are quite different, but the results are the same. We need high quality tests that produce an actionable result. And as we look at future IVDs or IVDs that we're developing, if we keep that in mind, we can find opportunities to work with those tests in low resource settings to actually create access for patients very early on. Next slide. And just hit the button 2 more times. Sorry, Lorenzo. And just as an example, I'll conclude with the Breast Cancer Global Initiative has an objective of averting 2.5 million deaths from 2020 to 2040. And pillar 2 of this program is timely breast diagnostics. And what you can see if we compare these is that the standard histology with IHC currently in the US is about 48 to 72 hours, best case scenario. But what we find in low and middle income countries is it can be weeks to months. With cytology, similarly, but it's usually days to weeks when it's worst. Standard histology with rapid RNA, for example, the breast strat4 example is about 24 hours to days. So that's really a great improvement. Cytology with rapid RNA is hours to days, which is also a great improvement. But with multi-cancer early detection, note that it's now back to days to weeks. But because of the interpretation, the testing needs to be done, but this is usually pre-treatment for an invasive cancer. Hit one more slide, Lorenzo, I'm sorry. One more button. it should be another image. There we go. And so what you can see is that if we look at where we are on the left of this with advanced countries, where we have mortality is decreasing in these countries because of the tools we have, and on the right where we see LMICs are, where they're at the apex of that and they need to decrease, the time is really right to intervene across the entire spectrum for breast cancer, but for the diagnostic interval to really be targeted, right? Their goal in that program is less than 60 days. But what you can see on the right is that even with really good standard care, we can do that now. So we don't need a lot of new IVDs to make this work. But as those new IVDs come out, they will only make this better if we have that infrastructure in place to make the diagnostic interval continue to shrink. So the overall take home from this is that when you're looking at a program, for example, this is the breast cancer initiative, and you're thinking about diagnostics, again, don't let the perfection be the enemy of good. With standard tools, we can actually accomplish this. But as IVDs come along, we don't want to forget that those are just improving that even more, allowing us to do better with the patient interval and the treatment interval overall. And I think with that, I will conclude.
Thank you, Dan, for providing insight on the future, the possible future of IVDs, and also all of the challenges that go with it to ensure access globally. Our next speaker is Sue, who is Professor and University Research Chair in Global Health Economics at the University of Waterloo, and she's also a Fellow of the Canadian Academy of Health Sciences and a Fellow of the Royal Society of Canada. Her earlier work on the economics of nutrition is really well known. And more recently, she's worked on non-communicable diseases in low and middle income countries. She's worked in more than 20 low and middle income countries, including Kenya, Tanzania, and Ghana, and has also consulted for over a dozen UN organizations, international development banks, and international research organizations. She's currently Deputy Chair of the new Lancet Commission on Diagnostics, and this is what she will talk to us about today. Sue has actually sent in a pre-recorded presentation that we'll now play. Lorenzo, please, whenever you're ready. Thanks.
Thanks for inviting me to participate in this really important dialogue on a very important topic. I'm excited to be able to tell you about the findings of the Lancet Commission on Diagnostics, which has been working over the last 2 years and will launch its publication in October 7th. If you're interested in participating in our virtual launch, please do get in touch. The Commission has involved 25 commissioners from 16 different countries over a 2-year period, and it was somewhat unique in its scope in that we combined both diagnostic in vitro testing with imaging. And for cancer, obviously, both those modalities are tremendously important. We focused on access rather than on people's utilization of diagnostics. Although the latter topic is really important, we didn't have space to cover it in our work. And in my brief remarks today, I'm going to focus on how these main messages apply to cancer. So access to basic diagnostics is obviously vital for cancer. And while what hits the headlines tends to be fancy new technologies, personalized testing, fancy new diagnostic imaging machines, which cost huge amounts of money, in fact, to have broad population impact, it's basic diagnostics that are really important. For example, first-level hospitals cannot provide life-saving cancer treatments, cancer surgery, if they don't have hematology analyzers to protect blood transfusions for patients. Similarly, they can't provide chemotherapy and hormonal therapy for cancer if they cannot monitor patients' blood chemistry in order to do this safely. And finally, ultrasound is entering into broader use, but requires a lot of training on the part of the user and can be a potentially very important for as a first step towards detecting cancerous tumors. A key finding from the Commission is that access to diagnostics is poor. It's poor in low and middle income countries in particular, but also for marginalized populations in high income countries. we defined access as have availability of 8 basic in vitro tests as recommended by the WHO in its recommendations for positive pregnancy. These are key tests important at a particularly vulnerable stage of life, but important at all life stages. This also includes ultrasound. We also defined access as being available within 2 hours walking distance from home, again, following WHO's suggestions. Going to the first level hospitals, we also added 4 basic tests at that level. For the low and middle income countries, we were able to use the service provision assessment tool from the demographic and health surveys for 10 low and low middle income countries. And in some cases, we had multiple surveys for 4 of the countries to be able to assess changes over time. The findings were quite shocking, that although countries have invested heavily in making health centres available to their population with some considerable success, however, the countries typically have not had the budget available to continuously make diagnostic tests available. And such that although HIV and malaria tests are most of the time available, supported often by donor funding, that's much less true for the other basic tests. And ultrasound, which requires quite a lot of training on the part of the user, is only very infrequently available. Similarly, at the hospitals, although 2 of the key 4 tests were generally available, the other 2 were not. So how does this poor access to basic diagnostics impact cancer? We often think of cancer testing and treatment as occurring in cancer centers and in specialized referral hospitals. But if that's the case, it means it disadvantages those people who live in rural or more remote areas. And it's very expensive for those people to travel to the city, taking along a caregiver, and to stay for extended periods of time in the urban area to access diagnosis and treatment. And the end result is that there is a bias, that men are more likely to be treated and diagnosed. Similarly, those with higher education and higher socioeconomic status, and marginalized groups will be excluded. Also, some of the key interventions to prevent cancer need to be based at the primary health centers, such as hepatitis B screening and then treatment of affected pregnant women to prevent liver cancer in their offspring. And this is important with the demographic transition and the epidemiological transition. Cancer is becoming increasingly important as a source of mortality, and 4 cancers will be among the top 20 causes of mortality by 2030 and 2040. So what can be done? The Commission has many recommendations, and I'll focus on a couple of those, particularly relevant to cancer. First, it's really important to include coverage of diagnostic tests and examinations in universal health coverage. There is no great benefit of covering treatment if poorer households cannot access the diagnostics that they need in order to then access the treatment that is covered. And therefore, this has important consequences for equity. Another key tool is to develop a national essential diagnostics list. The WHO developed its first diagnostics list in 2018, and India so far has developed its own national list, but more countries need to do this. We know the benefits that have come from the more than 40 years experience with the national essential medicines lists, and this needs to happen for diagnostics also. And obviously, the essential diagnostics list and the essential medicines list have to be consistent with one another. Conditions that are being treated by the essential medicines need to be diagnosed by the essential diagnostics. How can we implement the Commission's recommendations? What's going to change in order to make what's been well known become actionable? So it's very unfortunate that the Sustainable Development Goals did not mention diagnostics despite their focus on medicines and vaccines. And one way to get greater visibility is to have a global diagnostics alliance to do some of the same tools and tactics that Gavi did for vaccines. And now is the time to do this. People are aware of the importance of diagnostics following the COVID pandemic. It's also important to prioritize in the National Essential Diagnostics List. This should not be just a kind of wish list or a shopping list. It has to be a prioritized list that gives countries the tools to be able to expand their availability of diagnostics in a considered way as resources become more available. And so in the Commission, we have provided a template for how to identify the key essential tests and which tests are required at the 3 different levels in the health system, namely primary health centres, first level hospitals, and specialised hospitals. Thank you for your attention, and I look forward to hearing your questions.
You're muted, Shalini.
Oops. Well, thank you, Sue. Thank you for providing us an overview of the Lancet Commission, especially the findings of the Lancet Commission, and also for pointing out that very important message that cancer diagnostics need to be included in National Essential Medicines lists. So thank you. Thank you for that. So before we start our discussion, another reminder to please send us your questions to the chat box. And in the meantime, I'd like to start off our discussion with a question addressed to each of the panelists. And this one's for you, Beatriz. You mentioned in your presentation that with regard to regulation capacity building and quality, you talked about expanding the WHO pre-qualification program to include more cancer IVDs. Can you expand about can you expand a bit about what WHO pre-qualification process is and how it helps access?
Yeah, sure. Thank you for that question, Shalini. So the WHO pre-qualification process, of course, has been in place for infectious diseases diagnostics for a number of years. And basically what it has helped is to generate and making publicly available independent technical information on the safety and quality and performance of the IVDs. And this gives really, according to international standards, the countries an opportunity to rely on an assessment that goes beyond your stringent regulatory assessments, such as CE marking or FDA approval, because of course we know that often while the stringent regulatory authorities are very well recognized and have high quality standards, they do focus on assessment in their local population, which may not necessarily be the best match to the LMIC population. So really this is where the pre-qualification process comes in by assessing the performance not only based on standards and within the laboratory of the manufacturer, but it takes it to the intended use setting and the intended user to generate some local data, and get assurance of the quality of the diagnostics there. It also helps to build capacity in country because those performance assessments are done in LMICs, so there's definitely a capacity building aspect around it. But really, most importantly, it creates a certain reliance mechanism that countries can use to streamline their regulatory approval processes. Yeah, and really, I think widening the scope of PQ to include some more cancer IVDs is something to be considered carefully, definitely based on priorities and opportunities.
Thank you. And Dan, this one's for you. In your opinion, what is the biggest challenge facing IVDs for cancer in the next decade?
So I think Sue's presentation really highlights the easy answers for that, which was not easy to get to, but certainly they're the obvious answers. One is access to existing and new IVDs for limited resource settings is really key as a challenge, especially the need for pre-existing infrastructure to use those IVDs. And I think Sue has highlighted that really well. The other is cost of those new IVDs relative to prior testing. So if we want to bring on any kind of new test or even use existing tests, we have to balance the cost of that with other disease costs. So for example, Sue mentioned HIV and malaria and TB testing, for example. If we want to bring on cancer testing, it can't cost 10 times or 20 times more than those tests. We have to have kind of a relative cost structure and a trade-off for increased value. But a unique challenge, I think, with IVDs, especially the newer ones, is integration of data or integrated data to generate high quality, effective IVDs. And that's especially true across populations. We can't develop these tests in a Caucasian, older population in the United States and expect them to work in a young African population. And so we have to really think very globally about the development of these tests and having data from all locations in order to make those tests effective early globally. And I think it's a big challenge because it requires a lot of integration and communication with sites now that may not have the infrastructure to provide that data, but it's definitely needed.
Okay, sure. Thank you, Dan. And so this one's for you. What is the balance between infectious diseases and the non-communicable diseases in the Commission's finding?
So I think previous work has often focused more on infectious disease, and that's something we found when we were actually looking for commissioners from different countries. And, obviously that's related to the burden of disease as it has been in the past, and you see organizations like the Global Fund also very much focused on infectious disease. Similarly, the first World Health Organization Essential Diagnostics list essentially evolved out of a key half dozen priorities that the WHO had focused on, hepatitis B, HIV/AIDS, malaria, TB, syphilis, and it had relatively little to do with the non-communicable diseases. But I think the innovation in the Lancet Commission was to look forward using the global burden of disease work from IHME to find where we will progress with disease by 2030 and 2040. And so there's a much heavier emphasis also on the non-communicable diseases. And to some extent, we were aided by data. There are more data, for example, on the cost benefit of using tests for hypertension and for diabetes than there are for some of the more unusual infectious diseases. So I think we've tried to strike a balance, also looking forward to the future. Thank you.
Thank you, Sue. So thank you, speakers, for all your interventions. Now I'll open the session so all of the participants can also take part. So let's see what questions we have in the chat box. And Lorenzo, please point out any that I've missed, if that's okay. So there is one question. Actually, no, I'll go. There's someone who has their hand raised. It's Galaxy 4, J4. My apologies, but if you could identify yourself and please go ahead with your question. Galaxy J4. I'm not able to see your name. And you're muted. Okay, maybe we'll move on to the next question. So this question is to Dan or Sue. Is there a global standard for quality assurance for IVDs? And has the Lancet Commission addressed the issue of quality?
So I mean, there are standards for different tests. I think one of the challenges, for example, the CLSI is the Clinical Laboratory Standards Institute. They set standards for cross clinical lab testing as an example. I think the challenge with cancer diagnostics is that the traditional method, which is histology or cytology, for example, have subjective interpretation. And so there is the WHO classification of tumors books that come from IARC in Lyon that explain how to classify tumors, but that classification requires subjective interpretation by a human being. It isn't like that there's a series of tests that you do and you get that answer. It still requires that human interpretation. So I think at the moment for solid tumor cancer diagnostics, the WHO classification is kind of a standard, but how you assure, which is what Mary's question is, how you assure that people are using that manual correctly, exactly classifying cases, exactly using those tools that are available. I don't think that that is globally a tool. There are local quality assurance and quality assurance programs. There are bodies that will do quality assurance around pathology and histology, which are often related to the process of how you do it, that you're doing all the steps correctly. But that subjective interpretation quality, which is what's the most important, really requires what's called proficiency testing or external quality assurance. And that, for example, is highly lacking on the African continent, almost non-existent for histology, whereas you do find it in the US and Europe. But those are often voluntary programs. They're not necessarily required to do that. So I think we have a long way to go with quality assurance around diagnostics for cancer, specifically for traditional IVDs. As we move into modern IVDs or new developing IVDs, which are more molecular based, it's a little bit easier to create standards because it's interpreting a test that's being performed kind of in an analytic fashion without subjective interpretation. But there again, standard of how you did perform that test, et cetera, is not necessarily dictated by any one body. So it's a little bit of a challenge right now, and I think it is a major problem.
Okay. Thank you, Dan.
Sue, I don't know if you want to comment as well.
Sue or Beatrice, would you like to comment as well? Please go ahead, Sue.
Sure. So yes, obviously we focused a lot on quality in the commission, and it was interesting to me as a non-expert in either area to note how different the quality assurance is for IVDs and for imaging. And so we lay some of that out in the commission. And Dan is correct that a lot of this has to be done quite locally. I mean, it's in the COVID epidemic, it turned out to be really important that labs could quickly develop their own tests for COVID prior to any molecular tests becoming available. And so having this good local capacity is tremendously important. So, and Dan also pointed out the issues in Africa. So Africa, like other regions, it's too expensive to rely on international quality assessment. So many of the countries like Malaysia have developed their own at a lower cost, but enabled more advances to be made. And that's a method that's being used in Africa with the SLIPTA program to try and bring up the quality. And it's being done on a regional basis because it's obviously there are advantages to doing that rather than country by country within Africa. So yeah, absolutely, quality tremendously important.
If I just may add on this, I think it's also so important locally to get a buy-in in quality. I've seen it in local diabetes clinics where we looked at the quality assurance and getting accreditation. It's the support from the hierarchy and allowing the staff to invest the time in quality and making available those capacities, however big or small they might be. There's tremendous impact to actually implementing any quality effort, and if there's a buy-in across and support at all levels.
Thank you, speakers. So there's another question. So the presentation dealt with using these tests and techniques to make a diagnosis. Any application in monitoring responses to treatment? I think, Dan, I'll let you start this one.
Yeah, so I think that's a great question there, that when we don't have something and we're trying to get it there and we finally get it there, we're like, oh, now we can finally do X. We don't realize that was just the tip of the iceberg for what that use or that strategy can be. And that's absolutely true in diagnostic pathology, is that it's true, we do need a lab in order to make a diagnosis of breast cancer, which we might do on a core biopsy or on a cytology. But then if that woman undergoes therapy and we do a mastectomy, we then need to review that histologically to monitor response to treatment that way. In hematological diseases, we make that diagnosis with flow cytometry, but then we really need advanced tools to do minimal residual disease testing down the road to make sure that therapy is working. So there's absolutely a role for the pathology laboratory or the clinical laboratory combined in monitoring patients for response to treatment. But as Sue pointed out, for so many places that don't even have basic laboratory standards, just getting a diagnostic system in place is really key. And then the monitoring becomes kind of an added on bonus that you do down the road once you have that lab established. So absolutely important, really key. Not as important probably as just getting a patient diagnosed early and on treatment. If you can get someone diagnosed early and on treatment, even at a point of that they're curative, then that monitoring and evaluation going forward becomes less important, obviously. But certainly that's not the case now, and that we do have patients that will need some ongoing monitoring. So yeah, it is important, and there's always an application of the lab in this area. But when we prioritize or think about priorities right now, we're just trying to get diagnostics on the ground in many of these places just to make the initial diagnosis, and we'll get to monitoring when we can.
Perfect. Yes, of course. And this question is actually to any of the participants. Would you like to add to that, Sue?
Yes, if
Sure.
that's okay. So
okay.
yes, it's tremendously important to monitor treatment. And also there are some treatments that are potentially toxic, and you have to measure the level of toxicity to the patient. So when we did our template for countries that would like to use it to allocate tests to different levels, we absolutely did include the monitoring tests required. And once you've got the diagnostic ones, the ones for monitoring treatment is a relatively small number, because you've got the important basis there. But yeah, these two things have to go hand in hand. Thanks.
Okay. Thank you, Sue, for adding to that. And that brings us to the end of the session almost. I think before we close, I'd like to ask our speakers just one last question. So if you could share just one idea with the audience that would be the most important for them to remember about what we've discussed today, what would that be? And may I ask Beatrice to go first? You're on mute, Beatrice.
Yeah, that's a good one. I think to me, when it comes to barriers to accessing IVDs, I think remembering that it's a complex ecosystem, because in discussions, we often end in a moment where we say, oh, where do we start? Do we start with regulation? Do we start with quality, with training, with cost? So really, I think the whole ecosystem, and don't be afraid of going one by one. We can't fix it all at the same time. Identify in your context or in the context you're interested in, what is the best sequence, of addressing these things in the long run to cover the entire system.
Thank you, Beatrice. Dan, would you like to go next?
Yeah, I'm going to step outside the box a little bit. I think that the one thing I really want people to think about is the fact that markets for current IVDs and the current way we use them, i.e. a patient has to present and then someone needs to decide to make a biopsy, et cetera, that market is quite small. And that's really limited industry's interest in investing in infrastructure in LMICs because there aren't systems to find those patients. But if we look at markets for broad screening IVDs, like multi-cancer early detection tests, that's an enormous market because it's essentially the entire population, depending on how you want to structure that. And that really represents a sufficient market force for investment and for profit while still providing high quality services to patients. And I think this really needs to be stressed and emphasized, that we're coming from an area where it was too, in quotes, it was too expensive to try to deal with cancer, but we're moving with these IVDs to an area where huge market forces are creating a profit opportunity for companies so that they should invest, and that investment will result in high quality care for patients.
Thank you, Dan. Please go ahead.
And I'm going to finish up, since I'm neither a clinician nor a cancer expert, and I'm going to say you've got to think big. You've got to think about the Sustainable Development Goals and universal health coverage. And if we don't fight to have diagnostics recognized there, none of these other things are going to be funded, and poor people will not be reached. Thank you.
Thank you, Sue. So those are all really excellent points and important messages. And in addition to what our speakers highlighted, we also hope that you all leave with the following messages. To ensure maximum resources, to ensure maximum use of resources, governments should select essential IVDs based on national needs and the capacity for treatment, and it must be aligned with national essential medicines lists, because medicines and IVDs go hand in hand. They have to be aligned at the national level. And governments should also consider emerging technologies, especially when these can address barriers to access and ensure that paths for registering them are not overly complex and bureaucratic. And finally, investment in appropriate evidence-based IVDs is vital not only for better treatment outcomes, but also for savings to health systems and it must be accompanied by accessible, high-quality treatment options. So with that, thank you, audience, and thank you, speakers, for your time today. I wish you all a wonderful afternoon. Bye-bye.
Thank you. Bye-bye.
Thank you.